Hello, everyone, and welcome to today's webinar, Laboratory Screening for Multiple Myeloma, a Nudge in the Direction of Guidelines Compliance. I'm Alexis Krause of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Binding Site. To learn more, please visit bindingsite.com. We encourage you to participate today by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Dr. Jeremy Hart, Medical Director of Clinical Labs at St. Elizabeth Healthcare. Dr. Hart, welcome. You may now begin your presentation.
Good morning, everyone. I will first want to thank LabRoots for the privilege of joining you virtually today. Certainly, COVID has created many challenges for all of us, but on the other hand, it's really opened up greater opportunities to connect virtually, and I really appreciate this opportunity to do just that. If you're a laboratorian like me, you have line of sight into the ordering behavior of all the clinical providers in your hospital or your system. And with that position of privilege as someone who does have line of sight, numerous examples may come to your mind in which you observe patterns of test ordering that aren't entirely optimal. It happens all the time in healthcare, and I'm sure that our industry is not unique in that regard. We've all experienced this. You know, overutilized tests contribute to waste in healthcare. On the other hand, underutilized tests represent missed opportunities. So the real question becomes, what is your strategy to nudge your system in the direction of best diagnostic laboratory practice? What's your go-to role? Are you a pusher? Are you a puller? As a laboratorian, how do you nudge your clinicians in the optimal direction without coming across as pushy, which honestly would be counterproductive? So I say we lay aside any tendencies that we might have to push or to pull or drag our colleagues along with us, and really consider what it might mean instead to nudge them. It's certainly true that no matter how effective a set of particular diagnostic laboratory tests, clinicians still are in the position where they have to select them for their patients. So a nudge is a way for us to help them select the right tests in a very respectful, collaborative way. And so I think we should keep in mind that our decisions are heavily influenced by the environment in which they occur. And this has really been studied very extensively by groups like UPenn with their nudge units. For ordering providers in the context of laboratory test decisions, this environment includes the electronic medical record. So small changes to the way test order choices are presented and how those orders are framed within the EMR really can lead to significant differences in the way clinicians order tests. So what I hope to share with you today is the story of how my system has begun to leverage the EMR to optimize testing for multiple myeloma and related diseases. So first, let me tell you a little bit about our system. At St. Elizabeth Healthcare, our mission is to provide comprehensive and compassionate care that improves the health of the people we serve. And our vision is that St. Elizabeth would lead the communities we serve to become the healthiest in America. Every year, our health system, located in the greater Cincinnati region, provides more than $130 million in uncompensated care and benefit to our community. We have 6 facilities throughout northern Kentucky and southeastern Indiana. In addition to that, we have 165 specialty and primary care offices, which are located in the tri-state area consisting of Kentucky, Ohio, and Indiana. And we're home to 10,000 associates and a medical staff of nearly 1,200 physicians and advanced practice providers. Every year, we have over 50,000 acute admissions or observations and over 3 million patient encounters. I want to give you a sense of our laboratories as well. We operate a joint venture core laboratory in partnership with another large health system in the greater Cincinnati region. In addition to that core laboratory, we have 9 hospital-based labs with an annual operating budget of about $70 million. Our laboratories employ over 400 full-time equivalents, and we have 10 pathologists on staff. Every year, we have approximately 6 million billable tests. So in the context of myeloma testing, just to give you a sense of the volume of testing that we have, we performed about 3,400 total electrophoresis studies in the last calendar year. That was 2020. So here are the key topics that we'll cover in our session today. We'll begin by briefly covering the classification and epidemiology of plasma cell neoplasms. Next, we'll review testing approaches and guidelines. And after that, I'm going to share how my system uncovered what type of testing was actually occurring, how we leveraged our laboratory information system to improve, and how we've monitored for efficacy. So first, let's start with a brief review of plasma cell neoplasms. Those include the proliferative disorders, the most important of which is multiple myeloma. There are also a handful of important diseases that have low tumor burden, and they exert their primary effects by the production of abnormal proteins. Among those are primary amyloidosis as well as light chain deposition disease. And finally, there are the pre-malignant conditions, and we'll spend a bit of time looking at one of those conditions later on, and that's monoclonal gammopathy of undetermined significance, or MGUS. Each of these diseases has a wide range of biology and disease presentation, and the first clue to the diagnosis often is the identification of a monoclonal immunoglobulin. The malignant disease, multiple myeloma, usually presents with a significant amount of M protein. But keep in mind, there are also non-secretory cases with little to no M protein. On the other hand, the low tumor burden diseases like amyloidosis or light chain deposition disease may only have small amounts of M protein, but their clinical implications may be severe, requiring early diagnosis and intervention. And even for the less common plasma cell disorders, they represent disease states in which diagnostic guidelines exist and where optimal test choices can impact patient care in a positive way. So multiple myeloma, of course, is the most important of the plasma cell neoplasms, and it usually presents as tumorous masses that are scattered throughout the skeletal system. The clinical features of the disease stem from the effects of a number of important factors. Among those are plasma cell growth in tissues and the production of excess immunoglobulin. Bone resorption often leads to pathologic fractures and chronic pain. These are things that often lead patients to present clinically for care. In the radiographic images provided on this slide, some characteristic lytic lesions are depicted. In addition to pathologic fractures and chronic pain associated with skeletal involvement, there are other clinical features that may present. Manifestations of hypercalcemia, for example. And that can really involve multiple organ systems and can include non-specific symptoms like constipation, fatigue, or depression, things that really normally wouldn't be easily attributable to a plasma cell disorder. Renal disease is also very important to consider. Among numerous factors contributing to renal damage is the toxicity of the excreted light chains in renal tubular epithelial cells. And then finally, there are the typical hematologic manifestations of plasma cell disorders, and that includes anemia. So compared to solid tumors, lung cancer, breast cancer, for example, multiple myeloma is relatively less common. However, according to statistics provided by the American Cancer Society In 2021, nearly 35,000 individuals will be diagnosed with multiple myeloma. And of those 35,000 new cases, slightly more than half of those are predicted to be in men. The incidence is also expected to be higher in individuals of African descent. And also keep in mind that it's chiefly a disease of older adults. And the peak incidence is generally in the age range of 65 to 70 years old. In fact, really fewer than 2% of all new cases occur in individuals who are younger than 35. Again, according to statistics from the American Cancer Society, in 2021, approximately 12,000 deaths are expected to occur from multiple myeloma. And the disease itself actually represents about 1% of all cancer deaths in Western countries, with a lifetime risk of 1 in 132. So several new treatment options have been FDA approved in recent years, targeted therapy, immunotherapy, for example. And what these drugs are doing really is extending the life of multiple myeloma patients. So if you look at our regional patient population, again, in the greater Cincinnati, Ohio region, we've seen an uptick in our identification of patients diagnosed with multiple myeloma. In each of the last 2 years in which cancer registry data was available to me, again, these were the years 2017 and 2018, we identified nearly 40 new cases in each of those years. So just as new treatments are extending the life of multiple myeloma patients, early detection is also a very important strategy. MGUS, I mentioned that earlier, monoclonal gammopathy of undetermined significance, is considered a precursor state. And I think it's important in this presentation to highlight our current understanding of MGUS progression. Kyle and his colleagues at Mayo have written extensively on the topic of MGUS. So they reported in 2006 on a cohort of over 1,300 patients who were diagnosed with MGUS in southeast Minnesota. And they published that the probability of progression was determined to be around 1% per year, with a cumulative probability of 30% at 25 years. Some predictors of the progression of MGUS to myeloma included the size of M protein. So important to point out that there's nearly a 50% risk of progression for those who have an initial M protein of at least 25 grams per liter. The type of involved heavy chain may also predict progression, as there is an increased risk of progression for IgM isotype. Other predictors include the percentage of bone marrow plasma cells and the serum free light chain ratio. Importantly, the serum free light chain ratio may predict progression independently of the size and type of monoclonal protein. Now let's shift our focus to different test approaches. And I really like to share this publication. It's a great publication by Jonathan Gensen from 2018, and it highlighted the most common approaches used by ordering physicians when screening for monoclonal gammopathy. So just to point out some of the serum tests that are used for screening and diagnosis, those include serum protein electrophoresis. There's a couple different methods for serum protein electrophoresis. That includes agarose gel electrophoresis, which we do in my laboratory, also capillary zone electrophoresis. That's in addition to immunofixation electrophoresis, serum free light chain studies, and quantitative immunoglobulins. Urine studies may also be important in some cases, so urine protein electrophoresis and urine immunofixation may be used to identify Bence-Jones proteinuria. So Gensen's work, again published in 2018, was the result of an international survey of laboratory practice. So this survey included labs, 700 different labs from 38 countries, so it was a wide sample. So they completed the survey, and one of the most interesting findings in this study really was the response to the question, what is the most common approach used by physicians who send specimens to your lab for initial evaluation? So the responses really demonstrated significant variation in practice. The most common approaches, these are highlighted in the red box on this slide, were serum protein electrophoresis with reflex to immunofixation, serum protein electrophoresis alone, or the combination of serum protein electrophoresis and immunofixation. And together, those three different approaches comprised over 70% of total responses. Importantly, what all three of those approaches have in common is that they lacked the addition of serum-free light chain studies. So the other thing that they pointed out in the study was that fewer than half of labs offered panel testing for ordering convenience. So the study really highlighted at least one, if not more, important gaps. And really the gap I'm thinking of here is the exclusion of free light chain studies. But so important because serum-free light chains are very important biomarkers for the diagnosis and the management of plasma cell disorders. In multiple myeloma, for example, the determination of free light chains is used not only in the initial diagnostic assessment, but also used during follow-up. Just for example, a normalized kappa-lambda ratio, which is determined by serum-free light chains, is one of a handful of criteria used for the determination of stringent complete response, along with a negative IFE in serum and or urine and plasma cells in bone marrow less than 5%. So the importance of serum-free light chain studies as a biomarker was actually highlighted by the introduction of a new definition of multiple myeloma disease. And according to the recommendations of the International Myeloma Working Group, or IMWG, the ratio of involved to non-involved free light chains helps to differentiate between smoldering multiple myeloma and multiple myeloma that requires treatment. In fact, in the IMWG's 2014 update, free light chain ratio greater than 100 is considered a myeloma-defining event. Even more recently, if you look in publications even from last year, new criteria for high-risk smoldering multiple myeloma were defined. There's a new rule called the 2-20-20 rule, and that consists of a serum protein level of greater than 2 grams per liter, a free light chain ratio greater than 20, and bone marrow plasma cells greater than 20%. And patients who meet these criteria tend to be a subgroup of smoldering multiple myeloma patients who have an increased rate of progression within 2 years. And these patients may benefit from early treatment intervention. So in plasma cell disorders other than multiple myeloma, the assessment of free light chains is also very, very crucial, and it has potentially wider implications in treatment decisions. As I mentioned earlier, amyloidosis and light chain deposition disease may have only a small M protein and may not be detectable by serum protein electrophoresis. So assessment of free light chains is very crucial. Therapeutic response in both primary amyloidosis and light chain deposition disease is nearly solely based on the percentage and absolute decrease of involved to non-involved free light chains. So honestly, we can't overstate the importance of including serum-free light chains in both diagnostic and monitoring strategies. This is another great study by Katzman, published back 12 years ago. And in this study, Katzman demonstrated the sensitivity of different screening approaches for different plasma cell disorders. This was on a cohort of over 1,800 patients. So a number of studies, including this one, have shown that the addition of serum-free light chain studies to protein electrophoresis can replace the need for urine studies in multiple myeloma. Now, a key finding in this study by Katzman was that no test performed optimally when used as a single screening test. When considering just the task of screening for multiple myeloma, really just a simple screening panel of protein electrophoresis and free light chains was shown to be adequate. And you can see that highlighted here in the upper red box on the slide. The sensitivity of that combination of tests for the identification of multiple myeloma was shown to be 100%. However, For other diseases, and you can see in the bottom two rows, primary amyloidosis and light chain deposition disease, urine studies really should not be omitted in those, if you're looking for those diseases in order to maximize sensitivity. And you can see at the bottom there, moving to a combination of all tests, which includes both serum and urine studies as well as serum-free light chains, results in the optimal sensitivity when you're looking for amyloidosis or light chain deposition disease. So certainly using the most comprehensive panel, serum and urine tests, was shown to be the most sensitive. That makes sense. But because of the small incremental increase in sensitivity, really in most cases the use of serum protein electrophoresis and free light chains provides a very simple and cost-effective initial diagnostic screen for the high tumor burden diseases like myeloma. So for all these reasons mentioned in the prior slides, it's the combined use of protein electrophoresis and free light chains which is recommended by the IMWG. And the NCCN also supports a use of a panel of tests, including serum-free light chains, in the initial diagnostic workup. And what I anticipate will happen later on this year is that the College of American Pathologists is soon going to publish a series of diagnostic recommendations which will further support what is the optimal approach for laboratories. So after understanding the guidelines, it really was important for me as a laboratory director to pivot to a key question. And that key question was, how was St. Elizabeth Healthcare doing with regard to adhering to the published evidence? And really, this is the question that led my team and me down the path of discovery. So here at St. Elizabeth Healthcare, we utilize the Epic EMR as well as the Epic Beaker Laboratory Information System. And these systems have several tools that can assist with discovery. So we queried Epic Beaker using a reporting workbench tool for all related tests ordered during the period beginning November 2018 and ending November 2019. We did make a few assumptions. We made the assumption that non-oncology clinicians were testing to screen for multiple myeloma, while oncology initiating testing was predominantly for the purpose of confirmation or for monitoring purposes. So then we calculated guideline compliance rates by specialty. And so what we discovered after our audit, and these are actually results that we published in a 2020 AACC annual meeting abstract, was that there were 11 unique testing combinations ordered during about 4,000 individual patient encounters. So around 55% of the encounters were in non-oncology settings, and these encounters honestly were the ones we were most interested in understanding. And if you look in the middle column here that highlights the approaches used by primary care providers, they quite honestly demonstrated the lowest adherence to current guidelines at over 10%, just over 10% adherence. So the green boxes that are highlighted in this column represent test combinations that would be considered compliant with guidelines. Importantly, we observed a significant number of serum protein electrophoresis only orders. And those comprised 139 of the approaches in the primary care setting. The total number of protein electrophoresis orders that lacked the recommended serum-free light chain studies comprised more than 80% of encounters in the primary care setting. And so this was worrisome to me as a laboratory director. And on a broader scale, 63% of all non-oncology orders were comprised of test combinations without recommended free light chain studies, or in some cases urine studies. Now, if you compare my system to the findings of Ginzen, remember he found that 72% of the respondents were not adherent to guidelines in 2018. Perhaps our system performed a little bit better than that group, but still there was certainly opportunity for improvement in our system. So what I have found working with clinicians is that encouraging adherence to a diagnostic test guideline, if that's an end unto itself, really isn't perceived by clinicians as a motivating force. But on the other hand, what really should be motivating to all of us in healthcare is the opportunity to reduce the time to diagnosis. So using a model originally published at the 2017 American Society for Hematology annual meeting, we theorized here in our system that there would be a significant reduction in the time to diagnosis from 149 days with my current system, with my system's current pattern of utilization, down to 45 days if following the recommended guidelines. And really, this difference could positively impact avoidance of downstream complications and their associated costs, things like chronic renal impairment, infections, and neurologic or bone disease, things that tend to cost a lot of healthcare dollars. So affecting change looks differently at every institution, and the laboratory is going to be positioned differently in different institutions, different systems. At my institution, significant changes to the laboratory formulary or other impactful changes are first vetted through the Clinical Laboratory Advisory Committee, or we like to call CLAC for short. This is a multidisciplinary physician-led committee that's been around for about 2 years, and this group is responsible for promoting and facilitating test optimization opportunities in a fiscally responsible manner. So when we launched this committee, we ensured that it reported up the leadership chain within the organization to the Medical Executive Committee and had the backing of the Medical Executive Committee. So in addition to reviewing and approving order sets containing diagnostic tests, other examples of our past projects have included restriction of Q24-hour laboratories, prevention of duplicate once-in-a-lifetime genetic tests, and then the creation of new order panel cascades. This might be the best slide in the presentation, honestly. What we created for consideration for CLAC were 3 new EPIC order panels. And the goal of these order panels was to guide providers in the direction of the optimal guideline-compliant test selections. These panels were initially vetted by hematology specialists as well as our cardiology specialists, and they had reached out to me specifically requesting an amyloid evaluation panel to be used in their heart failure clinic. So our Clinical Laboratory Advisory Committee approved these proposed panels with an initial launch that occurred in the summer of 2020. So I want to point out some key features of these panels. For the screening panel, which is depicted at the top of the slide, we opted to continue with serum protein electrophoresis with reflex to immunofixation as opposed to default ordering an IFE study for all the screens. We clearly stated on the myeloma screen panel the sensitivity of that combination of tests for all plasma cell disorders, which is over 94%. And really 100% if you're just considering multiple myeloma. We wanted to provide that information really to reassure providers that this was an optimal combination of tests. If you look down at the amyloid evaluation panel, we included urine studies, and that was on purpose to maximize sensitivity of detection. And then if you look down at the monitoring panel for myeloma, we made urine studies an unchecked option in the follow-up or monitoring setting. Now, if you go back all the way to one of the first slides I showed you, and the concept of the nudge, I want to go back to that because we built these panels without restricting choice. In other words, all the tests can still be ordered individually by the clinician, and the pre-checked options can be modified at any time. The test selections are clear to the provider, and it's really easy to opt out. And that's really key in the nudge. You want to make it transparent and easy to opt out so that you preserve provider choice. So it would have been nice if the expected modifications had been immediately successful. However, we encountered implementation challenges. Those included things like difficulty finding all the EPIC locations where non-optimal test orders were located. In addition to the fact, EPIC has a functionality now where physicians can create their own preference lists within EPIC. So when you're trying to do search and replace functions with test orders, it can be very challenging. The other thing we recognized was that despite calling out the new panel options, we wanted to market them and let physicians know that they were available. And we did that through our regular physician communication channels. There was still, despite the communication, a high likelihood that the updates we were sending were going to be missed by physicians in their inboxes. So ultimately, we discovered that despite our effort, all the appropriate preference lists we originally assumed had been updated in August of 2020, in fact, had not been updated. The updates had only occurred on inpatient ordering contexts within EPIC, not the ambulatory lists, which were actually more crucial for the success of our project. And the way we discovered this was by closely monitoring for some expected impacts. So first, we looked for impacts to test volumes. We were looking for things like fewer serum protein electrophoresis only orders or increased free light chain orders. Second, we partnered with our EPIC order specialist to create an order panel utilization report using the Clarity database that's built within EPIC. Monitoring that report became very helpful for us because it confirmed to us that the new panels were only being used in the inpatient setting, which was very odd to me. So it prompted us to take quick action to address the problem and ask the orders team whether or not the outpatient ordering context had been updated with the appropriate panels. So I wanted to show you an example of a custom report that we generated using EPIC Slicer Dicer. If you're unfamiliar with EPIC, Slicer Dicer is a self-service query tool that's built within EPIC, and it allows users like me to have quick view into patient populations. The data are pulled from the back end of the EPIC data warehouse. So what this report demonstrates, and I apologize that the axes are so small and you can't really see, but what it's demonstrating is the monthly number of encounters in which there is a protein electrophoresis order concurrent with a serum-free light chain order. And the timeline goes from August of 2020, that's the first data point, all the way to April of 2021, the last data point. And so what we have observed is a very significant uptick in the monthly number of orders that are considered guideline compliant. And that change really flipped for us between February and March of this year. We also monitor a monthly order panel utilization report, again, as I mentioned, generated automatically via the EPIC Clarity database. This monthly report actually is emailed. It comes to my inbox every month. And we can clearly see, if you're looking at the left-sided graph, the uptick in utilization of the myeloma screening order panel. And this is the time frame that's depicted here is from January of 21 all the way to April of 21. On the other hand, if you look at the right side, that's the amyloidosis evaluation panel utilization. It remained rather stable throughout that same time period. And that's because our impact had happened earlier. We had quickly been able to get uptake of utilization with the small group of cardiologists because they were engaged, they had asked for the panel, and they began using it immediately. So we had impacted change back at the end of 2020. So for 2021, we're just demonstrate stability of utilization by that group. If you look at overall utilization of all our new order panels, and I don't have this depicted on the slide, but it went from 24 uses in October of 2020 to 81 total uses during the month of April of 2021. And that represents an over 200% increase in utilization of our new panels. And this slide further demonstrates our success, particularly the success in the primary care setting. In 2018-2019, that was the initial time period for the data that we evaluated. 80%, I mentioned this earlier, 80% of our evaluations lacked the serum-free light chain studies. We've been able, through our efforts, to reduce that percentage down to 32% lacking serum-free light chains in early this year. Another thing we've looked at is serum protein electrophoresis only orders. Those orders went from 11% of all diagnostic workups in 2020 down to only 3% in early 2021. So in conclusion, our audit findings highlighted a gap in test order optimization. Here in our system, we leverage various tools in Epic. However, where you are, you may have another electronic medical record or laboratory information system, and I'm sure they have similar tools that make the investigative work much easier. So with the availability of tools like the ones I've shown, identifying opportunities, quite honestly, is the easy part. Guiding change, however, is a much more challenging position to be in. So really active engagement with clinician leaders via a laboratory stewardship committee like the one we have here is a very, very important strategy. As the laboratory medical director, it's also very important to cultivate relationships with other health system leaders, leaders like the chief information officer, your chief medical information officer, your chief quality officer, and others. These relationships strengthen the laboratory position, and particularly when you're trying to make changes within your health system, you have to have the buy-in. If you're changing clinical practice or making changes with the EMR, you've got to have buy-in from your other clinical and administrative leaders within your system. And I'll leave you with one last take-home message, and that is, as laboratorians, we are in a position of privilege. That is, we have line of sight to the ordering behavior of all our clinicians in our system. And as a response to that, we have the responsibility to leverage our unique position to drive conversations about the patterns we observe and to nudge healthcare providers, again, nudge healthcare providers to optimal test choices. So with that, I really want to move into the Q&A time and happy to answer any questions you might have.
Thank you, Dr. Hart, for that informative presentation. We are now going to start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. So Dr. Hart, let's get started. In your study, you cited primary care as your target improvement area. How did other clinical specialty areas compare from a compliance perspective?
So that's a very good question, and one we were also interested in, because we do know that these type studies are used by diverse specialties. The nephrologists in our system, neurologists in our system, also frequently are orderers of these panels of tests. So in the abstract that we published, we specifically called out our nephrology and neurology specialists. They were slightly more compliant with the optimal test guidelines. I think, if I recall, the nephrologists were 26% compliant with guidelines, and the neurologists were 17% compliant. So still quite a gap. It was a little bit more difficult for us to understand compliance for the hematologists, oncologists, because we weren't entirely sure when we evaluated the data set. We had to make the assumptions, as I mentioned in my talk, that they were ordering primarily for the purpose of confirmation or for monitoring. And so for confirmation, for example, if an outpatient primary care evaluation included, a limited test or a serum protein electrophoresis only, and the oncologist followed up with a free light chain study, it appeared in the data set to look like it was just a free light chain only order. So it was a little bit more difficult for us to make definitive conclusions about the patterns of test ordering on the oncologists.
Great. Thank you so much, Dr. Hart. Moving on to our next question. How long would you say it took your health system to implement this project?
So if I were to go back through my email inbox and try to find the very first time that I initiated a request to our IT here, it probably, if I added up all the months, it would be probably 12 to 15 months. And that seems like a lot, but it quite honestly could have been longer. And I know from prior experiences that these projects can tend to drag out long periods of time. And it becomes very frustrating for the laboratory because you expect to see progress and you don't see it and you don't know why you see it. So I would say that for our system, we have a very collaborative relationship between our Epic IT folks and our laboratorians. And so through regular meetings, through emails, phone calls, we're able to move things through very quickly. Now, I did mention in the talk that we did vet this project through leadership here in our health system, and that can add a little bit of a delay, but our laboratory advisory committee meets every other month, and MedExec meets every month. So honestly, those are very reasonable timelines, I think, for implementing projects. The hard part, the thing that took quite a bit of time was getting the utilization reports built. And so we had to go back and forth with our Epic order specialist to create that custom report so that I could really have a line of sight to who was using our newly created panels. And so that honestly can be quite a bit of time can elapse for systems where you're wondering what the response is and you're looking for an expected response and you don't see it. And so getting the custom report built so that we knew, so that we could really evaluate clearly what the impact was, and getting that report right was probably the biggest challenge for us.
Understandably, and going back to a time, just a follow-up question, what were the most time-consuming elements of it?
Yeah, I think getting that custom utilization report, that was probably the longest step. And really, monitoring for efficacy, you just can't neglect that part. And we would go back and forth. And I think I mentioned in the talk that we first, it took a couple months for us to realize that the only providers who were using the new panels were inpatient providers. And really, the inpatient setting is not where the majority of these workups are happening, and we were not seeing outpatient providers use them, and we wondered, why is that? And so I had to go back and forth with our Epic orders team, and we had to figure out where the order panels had been placed, what preference lists they were on, which preference lists were they not on. And so that's probably the most time-consuming part, was figuring out, are these order panels in the proper location within the EMR so they get seen by the providers you want to see them.
Thank you so much, Dr. Hart. And we want to thank our audience for all these amazing questions that are coming in. So, Dr. Hart, our next one. What do you think are the most effective ways for laboratories to influence clinician behavior?
Yeah, that's a very good question. Going back to the concept of the nudge, I think that's a very important concept because when we don't see the results that we want to see, it might be our knee-jerk reaction might not be to nudge, but to complain or, not go about it in the optimal way. I think nudging clinicians in the right direction can involve sometimes some subtle things, like, again, building the choices within the electronic medical record in such a way that it's not difficult for a clinician to do the right thing. And so I think that order panel design, naming of tests, those are maybe indirect ways, but they're very important ways that the laboratory can influence clinicians. Clearly, forming relationships is crucial. And so when I first came to my current role, within the first 6 months that I was here, I made a point to visit every single department head in our system and to go to their office and to have time and sit down with them and ask them what were their what were their concerns from a laboratory perspective, and forming those relationships from the very start of my tenure here was very, very important. I think has positioned the laboratory in a very positive light in our health system.
So Dr. Hart, our next question is a two-part question for you. First portion is, can you comment on your involvement with Epic in getting the panels up and running? And the second portion, do you have any additional words of wisdom?
Sure. So to get those panels up and running, I initially created, again, what the panels looked like, what tests were included in the panels, gave them a name. Then again, they were vetted by the Clinical Laboratory Advisory Committee, and on that committee, we have representation from both the inpatient Epic team and the ambulatory Epic team. So once they were vetted by the advisory committee and then approved by medical executive committee, it really was back and forth between me and the Epic team, making sure that the new order panels were on the appropriate preference lists, and then working directly with the Epic team in order to create the custom reports that we needed in order to monitor for uptake and efficacy. As far as additional words of wisdom, I would say one of the things we have tried to do here, and so I meet monthly with our Chief Information Officer, and early on, I tried to convince him that the laboratory was a goldmine of data. And so I see the mission of IT and the mission of the laboratory to be very similar in that, the laboratory has tons of data, the electronic medical record has tons of data, and we're trying to evaluate the data and then derive insights from the data and then present the data to make decisions. And so what we've done here is really try to integrate both our LIS team, the Epic Orders team, and there's a bunch of different IT teams, our BI team. We've really tried to integrate with the lab. In fact, recently, this was within the last 2 years, we hired a clinical lab data analyst who, we hired to sit within the laboratory, and yet that individual has a direct line of connection to the Epic BI team. And so that further cemented the relationship between the IT side and the laboratory side. Quite honestly, the laboratory is the only department within our health system who's chosen a model like that with regard to data analytics.
So Dr. Hart, our next question for you is a two-part question as well. You mentioned difficulty in creating awareness of the new order options. What avenues did you use to communicate the new order options? And the second part, was it email only, or were there other communication tools your hospital uses to communicate such changes?
Yeah, so this is a great question, and it's a challenge for any health system. How do you get important information to very busy clinical providers? And so we actually opted in this case to stick with the regular communication channel that we have in our system to communicate to providers, and that is through a weekly email flash that goes out. So all of the content related to these new order panels we send out via this regular email update. Now, recognizing that communication is a challenge, that's where the design of the order panel build and how it's placed in the EMR becomes very important, because with a really well-designed nudge, you may not even require some official marketing campaign or communication because you've positioned the new order panel in such a way that it becomes hard not to use it. And so in a day and age where providers are so uber busy and communication is a challenge, really that order panel design and how you place it in the EMR becomes even more important. And so the second half of that question was about whether we used email. I think I answered that, yes. So yeah, it was primarily email.
Great. Thank you so much, Dr. Hart. And before we let you go for the day, we've got one final question for you. Do you have any advice for other health systems out there who are looking to implement a project like this?
Yeah, be patient and don't give up. Honestly, the hard part is not the getting the panel out there. It's the hard work of monitoring for efficacy. So you've got to do that part, because you can't really improve without making sure that what you have done has had the intended impact. And so that can take months. And in our case, it did take additional months of figuring out what the implementation roadblocks were. But by doing that and really looking for expected impacts, then ultimately you can get to where you hope to be.
Thank you again, Dr. Hart, for your time today and for your important research. We'd also like to thank LabRoots and our sponsor, Binding Site, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions that we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information that you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, thank you for joining. Bye-bye, everyone.